Assalamu alaikum. Good morning. Good afternoon. I'm so sorry. I thought that I'm sharing the screen and I was expecting you guys to tell me that you can see it. But anyway, all right. So, diarrhea, very commonly tested, NACOSK and MCQ1. Okay. So, how diarrhea appears in a NACOSK station? First of all, acute watery diarrhea. Acute water diarrhea, short history, hydration, symptomatic care. If it is acute bloody diarrhea, remember it is more likely to be inflammatory or infectious. So it means that we need to do a culture. So for the diarrhea, we don't do investigation for every single diarrhea station or cases. We usually uh, uh, escalate the investigation when we have problematic or inflammatory or infectious diarrhea. Otherwise, watery diarrhea is self-limited. We just treat it symptomatically. Okay. But if it is acute bloody diarrhea, then we have to escalate. We have to do further investigation. We have to run some cultures. But one of the most important thing that you need to remember, if there is fever, remember two things. If there is fever with diarrhea and if there is blood in the stool, please do not go and prescribe the patient loperamide or any anti-diarrhea agent. Travel, if the patient has diarrhea secondary to exposure to some certain foods or, for example, unsanitary water or unhealthy water or untreated water and food, and the patient had a travel recently, so empiric treatment when moderate to severe. Antibiotic, uh, you might get a case of somebody that who is, let's say, 75 or 70 years old. The patient is having diarrhea. The patient is brought to emergency department from the nursing home, or the patient was recently admitted to the hospital and now the patient has diarrhea, or the patient was taking or receiving chemotherapy and radiation, and now the patient is having diarrhea. So it means that it could be Clostridium difficile. So risk factor, we have to find it, and testing, we have to test for the Clostridium difficile, infection control, and targeted therapy. Chronic could be either inflammatory, malabsorption, or it could be functional. So any diarrhea above 4 weeks is considered to be chronic. Steatorrhea or malabsorption. So if in the scenario they're mentioning that the patient has diarrhea, but it is foul smelling, it is greasy, and the patient is losing weight, then think about steatorrhea or malabsorption. Think about pancreatic uh, conditions. Think about celiac disease. Think about any condition that causes malabsorption of vitamins, especially fat-soluble vitamins. IBD flavored diarrhea station. For this one, usually the patient will have blood, urgency, tenesmus, and extra intestinal symptoms. For example, if it is Crohn's disease, the patient will have uh, ulcer in the mouth as well. And counseling discharge. So for the station with the counseling, you may not, uh, uh, you cannot afford to forget the ORS, the red flags, which we are going to go mention it. And when to return, you have to provide them with a safety net. It means you have to let the patient know when is a good time to come back. If these are the condition, if it happens, then you have to come back as soon as possible and seek medical attention and public health issue as well. So now the clinical framework classified diarrhea before you chase the cause. So it means we need to know if this is a acute condition, subacute condition, it's a chronic condition. Is it from the small bowel? Is it from the large bowel? Or is it inflammatory or it is non-inflammatory diarrhea? So basically, first I have to have this clear vision of what am I dealing with. So if it is less than 14 days, less than 2 weeks is considered acute. Anything above 2 weeks to 4 weeks is considered subacute. More than 4 weeks is considered uh, chronic. So if it is small, if the patient, if in the scenario or instruction it is mentioned the patient has diarrhea, but the amount of stool is less, but it is small but frequent. So it means the patient has a small volume of diarrhea, but it is more frequent. So in that case, I will think more about colon or colon involvement. If it is large volume, watery stool, then I think more about small bowel. If the patient has diarrhea, which improves with the uh, fasting, I think about osmotic carbohydrate intolerance. And if the patient is having diarrhea but not improving with fasting, then I think about secretory as diarrhea, endocrine dysfunction, infection could be another reason. Inflammatory, the diarrhea could be bloody. Steatorrhea, greasy stool, maldigestion, malabsorption, pancreatic or celiac disease. The first 60 seconds, stability first, then stool pattern. So it means that there are some steps that needs to be taken before we start going after the cause and treating the cause. The first thing that we need to know if my patient is stable, if my patient has dehydration, so it means I have to start the hydration as soon as possible. Any diarrhea, any vomiting in the hospital will present with a dehydration. So volume status and mental status should be number one on your list. Check the pulse, blood pressure, orthostatic, capillary refill, mucous membrane. Look for the peritoneal sign. You cannot miss it. You cannot afford to miss it, please, because this is very important. And you should even verbalize it very loudly for the examiner that I'm looking for the peritoneal sign to rule out peritonitis, because this will save you a lot of mark. And they expect you to verbalize it. And remember that they don't know that you know it. So the only way that we make sure that we get this good score here, we need to verbalize it. Decide oral rehydration versus IV fluid early. Green light. Like these are, if you have it, you don't have to worry a lot because this could be self-limited and this is not very problematic, or the chances of getting complication or becoming complicated is very low. For example, if it is a watery stool only, if the patient has diarrhea but no fever, no blood, if it's short duration, if the patient is able to drink and hemodynamically stable. Red flag, these are the things that you cannot afford to forget when you're taking history. Please mention them in taking history. Is there any blood in the stool? Do you have fever with it? Is it like in terms of color, in terms of amount or volume? Is it like profuse diarrhea? Recent antibiotic, are you currently taking, or have you been treated for any condition, especially for infection? Is the patient immunocompromised, for example, HIV? And pay attention to the age of the patient. Severe pain, and as I mentioned before, that we have to make sure to check for the peritoneal sign. And if the symptom is more than 7 days. Now, for focus station, these are the things that you have to cover, like for the onset, duration, the frequency, the volume. Is it watery? Is it bloody? Is it greasy? Is there urgency, tenesmus, or nocturnal symptoms? Again, I forgot to add nocturnal symptom, which is also a red flag. Associated symptom, the patient has, is it only diarrhea? Because if it is only diarrhea and watery, I don't worry, right? The patient is in the gray zone and the green zone. So it is most likely to be self-limited. But do you have fever? If the patient has fever, then it changes the whole thing. If the patient has vomiting, if the patient has abdominal pain with it, weight loss, fatigue, dehydration, rash, joint pain, oral acid, dark urine, jaundice, then it changes my diagnosis. If the patient has travel, history of travel, if there was an outbreak, if the patient was exposed to untreated water, if there was any recent antibiotic use or hospitalization, or the patient was taking any sort of receiving any sort of chemotherapy or radiotherapy for any reason. Sexual exposure, men, sex with men, daycare, immunosuppression, laxative, metformin, magnesium, or another med. Background clues: IBD, celiac disease, thyroid history, family history of IBD, or GI cancer. Prior abdominal surgery, especially in the abdomen or GI system, cancer or immunocompromised status. All right, so focus physical examination. Let's say you have a station that you need to do a history and then do a physical examination. Now we know that for history, we need to cover all this, right? But what do we do for the physical examination? For the physical examination, again, we have to start it with a vital sign. If it is given in the door instruction, good. If not, I have to ask. I have to ask. And most of the time, like 99% of the time, they will provide it for you. They're not going to waste your time by doing the vital sign, check for the pulse, check for the blood pressure. They're not going to waste your time. You have a lot of better things to do in that 11 minutes rather than just doing the vital sign. But you will lose, like, let's say 5 out of 5 if you don't ask for it, because that should be top number one priority for you. General appearance and alertness. Always we start the physical examination with the general appearance of the patient or with a general inspection. Then pulse, blood pressure, orthostatic will be provided, or it will be already provided in a door instruction. GVP you have to check. Why? Because that if it is flat, then you can tell that the patient has lost a lot of volume or fluid. Mucous membrane, obviously, you have to check it. Scan triggers, capillary refill for the dehydration. Urine output, if relevant, you need to ask if the patient has, sorry, if the door instruction did not mention it, you need to ask for it. Do we have any information about the patient urine output in the last 24 hours? The examiner will tell you yes, no, and he will tell you whether it is normal or it is low. Why? Because it gives you an idea like how dehydrated my patient is, how severe the condition is. Examiner prayer and ask you if you want to impress the examiner, you need to mention this. I would assess hydration and hemodynamic stability of my patient before going deeper into differential. This will earn you a lot of mark. Why? Because the examiner will realize that you are prioritizing your patient's safety. Abdominal and targeted exam. We do know that when we do the abdominal examination, we always start with the hand, and then we move on to the face, with the eye, with the mouth, and then check the neck, which I mentioned the GVP, and then you move on to the chest. From the chest, you move on to the abdomen, and then you move on to the abdomen and do your physical examination, starting with an inspection. After an inspection, you need to do the auscultation. As opposed to the chest, that when you do the chest, you do the inspection, then you do the percussion, palpation, percussion, and then at the end you do the auscultation. But here in abdomen, after an inspection, you do the auscultation. And after auscultation, you start to do the palpation, percussion, and so on and so forth. But in an inspection, we need to comment on distension, whether the patient has a distended abdomen, whether it is normal or flat. If there is a bowel sound, we have to hear it in the 4 quadrants and report it if there is any. And tenderness, check for the tenderness, guarding, rebound, peritoneal sign, mass, or organomegaly. We have to verbalize any finding that we have in the abdomen. Otherwise, the examiner doesn't know. Remember, when you start touching the patient, if the examiner is sitting, he will stand up, come and stand by your side or right in front of you to see how you're touching the patient. Every single physical examination that you're performing, they have to see how you perform it. Is it professionally done, or you're just wasting your time or just making it up? Like most of the, not most of, some of the IMGs, if they haven't done the physical examination, they have no idea how to do it. They just do it the way they want it. And that costs them a lot of more. So you have to do it in a proper way that we have already done it in the physical examination, right? So sign of chronic disease: pallor, edema, weight loss, and mouth ulcer. So if you have these, and the diarrhea is more than 4 weeks, obviously it is chronic. So other than time, these are other findings. Station one, let's say you have acute watery diarrhea. If it is watery diarrhea, it is more likely to be non-inflammatory and it is more likely to be self-limited and it does not require to be treated with an antibiotic. Or we do not even need to overly investigate the patient. So what are the clues for acute watery diarrhea? Usually it will be large volume, watery stool, and little or no blood. Usually no blood. If they want to test you, they will make it very specific. Often upper preumbilical cramping. See, when we ask where is the pain, can you point to the place where it hurts? It really uh, makes difference because it helps you. If you're asking what is the characteristic of the pain, is it crampy, pressure leg, or stabbing leg? It really gives you an idea like what am I dealing with? Is it something like watery diarrhea, which is non-inflammatory, or am I dealing with something which is inflammatory, or it could be peritonitis, or it could be coming from the colon, right? So colon. So in this case, pointing or a rule of fingers pointing to the right place, it helps you at least to suspect a condition. For example, your patient has diarrhea. How is the volume? More. How does it have blood? No. Where does it hurt? Above the belly button. Or uh, it could be around it, but usually it is above. Okay. So what is the characteristic? The characteristic is crumpy. So now you think it could be a small bowel. It could be non-inflammatory. Usually viral or toxin mediated. Main danger, dehydration and electrolytes. Your differential, it could be viral gastritis. It could be food poisoning, perform toxin. It could be travel diarrhea, medication related, or early osmotic diarrhea. Management, uh, rehydrate the patient if the patient is stable. If the patient can take it orally. If not, then you have to start IV hydration. Consider bismuth or loperamide only if no fever. Remember, no fever, no blood. You cannot use loperamide or bismuth if the patient has fever or blood. Avoid unnecessary stool, culture, and uncomplicated brief illness. Give return precaution and reassess if persistent. Now, let's say station number 2, you get another station, which is bloody diarrhea. So for bloody diarrhea, the first thing that comes to our mind that we are dealing with a little bit serious condition. So it means this is inflammatory. The next thing that has to come or pop up in your mind that I have to do culture for this patient. And probably I will start antibiotic. Not 100%, probably. Okay, so why it matters? Blood or mucus stool, plus minus fever, small volume, high frequency. This is a small but more frequent, so it can come from the colon. Lower abdominal cramping. So this will be in the lower part of the abdomen as opposed to the small bowel, which will be above the belly button. So below the belly button will be the colon, and the large bowel, and above the belly button will be the small bowel. So that's why the location is very important. Where does it hurt? And the characteristic, right? And crampy. Urgency and tenesmus would be positive. So these are what the inflammation, urgency and tenesmus. Can represent invasive infection or IBD. Complication including perforation, hemorrhagic, and toxic megacolon. So these are the complication. And for those of you who does prepare for the MCQ one, these could be in your question as well, an MCQ one. So high yield causes, there is a mnemonic which is also mentioned in Toronto note, which is chess. I just added IBD, or chess. So I stands for IBD flare-up. So these are the high yield causes for the bloody diarrhea. So if you have a bloody diarrhea, just remember IHS, IBD, C for Campylobacter jejuni, and H for hemorrhagic E. coli, and E stands for Entamoeba histolytica. S stands for Salmonella and Shigella. Exam safe management. Send stool test when severe inflammatory. Avoid loperamide if blood present in the area or the patient is feverish. Do not reflexively give antibiotic to every case. So it means I can use the antibiotic, but it doesn't mean for all bloody diarrhea I'm going to give antibiotic. No. Escalate if toxic appearance or peritoneal signs. Now, two classic OSCE station, traveler diarrhea and colostrum difficile. Now, let's say you have two more stations. Let's go with one of them. Let's say you have a station that the patient recently had a trip to Mexico or had a trip to India or had a trip to, let's say, Pakistan or Afghanistan. Patient is back here and now the patient has diarrhea. So travel diarrhea, right? So usually it could be bacterial. It could be ATEC is classic or the travel diarrhea. Ask destination, where was the patient? Timing, the food, water exposure, travel companions. Mainstay is usually rehydration. Usually this rehydration. Consider empiric treatment. Azithromycin, ciprofloxacin, rifaximin for moderate or severe. Okay. Prevention, safe water, food precaution, prophylactic antibiotic usually not recommended. So this might be in the question. Please do not go for it. I have seen commonly mistaken. A high percentage of IMGs have chosen this, which is not the right answer. Now, let's say you have another case or station that the patient has diarrhea secondary to antibiotic. So recent antibiotic, hospitalization, nursing home, and chemotherapy. So one of them might be the reason. So you have a patient that who had recently hospitalized and now the patient has diarrhea. You have a cancer patient who received chemotherapy, now the patient has diarrhea. You had a patient that who had, let's say, tonsillitis and the patient was taking amoxiclav and now the patient has diarrhea. You have a patient brought from nursing home has diarrhea. So if you have these risks factor, think about Clostridium difficile. Think when diarrhea follows antibiotic, even the timing is not immediate. It could happen later. Send Clostridium difficile toxin test when indicated. Stop culprit antibiotics. So it means if the patient is taking amoxicillin and the patient has diarrhea, stop amoxicillin or whatever is the cause, clarithromycin, whatever it is, the culprit, what caused the diarrhea, I stop it first. That is the first and mainstay of the treatment. Now, depending on the condition of the patient, I will start the treatment. It means the first thing I do after stopping is to start supportive treatment. And then if the patient is not responding, I will go ahead and start the vancomycin. And if it is getting very severe, where the patient is developing hypotension, the patient is going in shock, and the patient is developing ileus, then I can also add metronidazole. Otherwise, the vancomycin will take care of it. Oh, here. It gets worse. Now, let's say you have another station which your patient has diarrhea, but the patient has it for, let's say, 35 days. So more than 4 weeks. So you think that I'm not dealing with acute diarrhea. I'm dealing with chronic diarrhea. So now I have to focus on inflammation, malabsorption, functional, endocrine, and medication. I have to cover them in my history. Okay. So this helps you to at least get rid of all these acute reasons. These acute reasons, I'm not even thinking about them. I'm thinking about inflammation, I'm thinking about malabsorption, I'm thinking about functional, endocrine, and medication. So, an inflammation, it could be IBD, inflammatory bowel disease, microscopic colitis, colorectal neoplasma, plasia. So, malabsorptive steatorrhea, celiac disease, pancreatic insufficiency, giardia, bile salt issue. Now, for functional IBS, lactose intolerance, dietary osmotic load. For the endocrine and medication, it could be hyperthyroidism, metformin, laxative use, magnesium, or other causes. So it means these are the things that I have to cover. The red flags in chronic: weight loss, nocturnal symptom, rectal bleeding, anemia, persistent fever, dehydration, family history of IBD, and cancer. Steatorrhea or malabsorption, if it is a station, let's say you have someone who has bulky, greasy, foul-smelling stool with a lot of flatulence. The first thing that comes to your mind, the patient cannot absorb vitamin, fat-soluble vitamin. It could be celiac disease. It could be pancreatic insufficiency. Most likely pancreatic or celiac disease. Okay, so history. We need to ask what kind of stool is that, right? Kokabe. The color, the odor, the amount, the volume, the consistency, and if it has blood in it, right? So weight loss and fatigue, gas, bloating, which is going to be very high. Deficiency symptoms. The patient will have anemia, bone pain, neuropathy, pancreatic, celiac, ileus disease clues. Most treatable cause could be celiac, chronic pancreatitis, pancreatic insufficiency, giardia, thermal ileum disease, or resection. Common investigation. So these are the things that you need to include when you're doing investigation. So if you have a history plus investigation, if you have a history plus management, you cannot afford to miss this. CBC, electrolytes, CRP. CRP is acute phase reactant. So it will be high in any inflammation, but very sensitive to bowel inflammation. It means if there is inflammation in the small or large bowel, this will go up. And celiac, the IgA and tissue transglutaminase, total IgA, these has to be checked. Fecal fat, Sudan stain, fecal elastase, as a context suggests. Remember, this is for the pancreatic insufficiency. Endoscopy, biopsy if indicated. Investigation strategy or the test because the history earns them. Usually no extensive workup. We don't do too much or randomly or haphazardly investigation for any diarrhea that we see, unless it is complicated, unless we know it requires investigation. For example, in terms of inflammation, in terms of being greasy, bulky, foul smelling, chronic. In that case, we have no choice, but we have to do it, right? So brief uncomplicated watery diarrhea does not need extensive workup. Even if you're getting a question as a post encounter or in MCCQ1, you have a patient who has only watery diarrhea, and it has been 2 days, no fever, no blood. And what is the next big step? CBC, CRP, for example, ESR, and just supportive treatment or systematic care, symptomatic care. Obviously, you're going for the symptomatic care. That's it. We don't do extensive workup if the patient is not having chronic or any other findings, as I mentioned before. No blood, no fever, severe pain, no or dehydration, management symptomatically, and review if not improving. Or if it is less than 7 days, right? Test commonly justified. Stool culture, microscopy when inflammatory, severe, or epidemiologically important. Clostridium difficile toxin, if recent antibiotic admission or chemotherapy. Ova and parasite, if prolonged more than 7 days, untreated water, HIV, main sex with main, parasitic concern, CBC electrolytes, CRP, TSH, select serology, and a chronic diarrhea, colonoscopy, ileoscopy with a biopsy if alarming features, which we did mention it before, right? Now, avoid these pitfalls. Do not shotgun every stool test and mild short-lived illness. Do not miss the STEC bloody diarrhea caution. Do not delay escalation in high risk or immunocompromised patient. Okay. Now, initial management algorithm. So how do we treat or do the management? I think I do have this picture. I'm not sure if I can find it. Okay, stabilize the patient, hydration, vitus, perfusion. Classify the stool. Is it watery, bloody, or greasy? Check rest, travel, antibiotic, immunosuppression. Target tests only when the story supports them. Treat or management or counseling, ORS, IV, symptoms control, selective antimicrobial. Symptomatic therapy or treatment, oral hydration in most cases. If the patient can take it from mouth, obviously we have to encourage the patient to hydrate orally. If not, then IV, if it is severe. Bismuth may help, but remember, loperamide only when no blood and no fever. When antimicrobial or reasonable, clear indication, Shigella, cholera, cholesterol deficit, travel diarrhea, giardia, entamoeba, cyclospora, use severity and host risk factor to guide treatment of the other causes. Let me see if I don't think I have it, but let me see. Yeah, I think I do have it here. Okay, this was. All right. So the treatment is, I hope you guys can see it properly. So the approach to acute diarrhea is fever or blood in the stools, severe abdominal pain, profuse diarrhea with a hypovolemia. So if the patient has all this, age is more than 65, if the diarrhea is more than 7 days, risky, an exposure, or it is a male who is having sex with other male, then in that case, we do this. If no, this. And then we see if it is improving. So rehydration and anti-diarrheal agent like loperamide, bismuth, and salicylate. So if the patient is improving, good. If not, then we have to reassess, consider the test. So the indication for the investigation are blood in the stool, recent antibiotic use, age is this, more than 7 days. And these are the additional investigation. Counseling station. Let's do the counseling station. So in counseling station, we have to educate the patient that what type of diarrhea the patient has. What are the steps that we need to take in order to control the diarrhea? And what are the steps that we need to do right now? And what are the steps that the patient has to take in order to control it? And what are the steps that the patient has to remember to remember, if they happen, the patient should come back immediately to the hospital or seek medical attention right away. And we have to provide them with the brochure that has all those information to how to take care of themselves or the patient or their family member who is having this diarrhea at home. ORS and rehydration, how we can do it orally, all this stuff, right? So a safe OSCE script is Right now, the main priority is to make sure you are not becoming dehydrated. So this is in the hospital, right? Your history sounds most consistent with whatever the condition is, whether it is acute diarrhea, whether it's a chronic diarrhea, whether it is travel diarrhea, whatever it is, you write it down here. I do not currently hear red flags for severe disease. I do hear features that means we should investigate further. So, or maybe you should say that I don't hear it, then I don't have to do further investigation. Treatment usually starts with a fluid replacement, which in all cases it will be the same, and we may add other treatment depending on the stool pattern and your risk factors. Discharge advice and safety net. Return urgently for blood in the stool, fever, severe pain, fainting, and ability to keep fluids down, reduce urine, worsening weakness. Avoid anti-motility agent if the stool becomes bloody or feverish. For example, you prescribe loperamide, but you have to educate the patient not to take it if you have fever, not to take it if you see blood in your stool. Okay, so these are part of the consultation. Or for example, you're discharging the patient with diarrhea, you prescribe him loperamide, but you do not counsel him on when to stop it, and the patient get complicated. Hand hygiene and food, water precaution, review the medication, and stop unnecessary laxative if relevant. Now, examiner language, phrase that sounds organized and safe. My first concern is hydration status and hemodynamically stability of the patient. I would classify this as acute versus chronic and watery versus inflammatory before narrowing the differential. So because there is blood, fever, severe pain, I would not treat this as a simple self-limited gastroenteritis. Recent antibiotic exposure raises concern for Clostridium difficile and change my testing and management. In chronic diarrhea, I would actively look for inflammatory, malabsorptive, endocrine, medication-related, and functional causes. If the patient is stable, oral rehydration is first line. IV fluids are for a severe dehydration or inability to tolerate them per oral. I would avoid loperamide in bloody diarrhea or fever. And you have to mention for the patient not to take it if it happens at home. My disposition depends on the red flag, host risk factor, and ability to maintain hydration. So, a few rapid scenarios. For example, you have 24-year-old man with 2 days of watery diarrhea after restaurant meal. So 2 days, 24, watery diarrhea after restaurant meal. So what is it? Acute, foodborne acute diarrhea. Because it is mentioned, right? 2 days, it's less than 14 days. So it is acute, right? If it is acute, what happened? What kind of diarrhea it is? It is watery. So it is acute watery, 2 days acute. What happened after restaurant meal? So it's food-borne watery diarrhea. So what should I do? Hydration, brief illness, no unnecessary test. So it means this is self-limited. Now, another station, 63-year-old with fever, cramping, and blood in the stool. 63, very close to 65, right? Above 65 is a red flag, but still good. But very close, right? Fever. Fever is red flag. Cramping and blood in the stool. Again, this is red flag. So cramping and blood stool. Okay, so maybe we should mention 63-year-old with a fever, cramping, and blood in the stool for example, let's say 4 days. Acute inflammatory. So it is still acute because it is less than 14 days and blood and loose stool for 4 days. Okay. So again, it is Six, maybe we should just change this one to 65, make it a little. Okay, 65, fever, cramping, and blood in this loses blood in the stool. Stool, maybe I should cut this. And mm, okay, now it makes sense. Now it is acute inflammatory. Why it's acute inflammatory? Because it is blood in the stool and the patient has fever, right? Stool workup, avoid loperamide escalation. So it means I will treat this as an inflammatory, not non-inflammatory. Why? Because the patient has fever, the patient has blood. So it is inflammatory. It means I have to do blood culture. I have to do some stool workup. But at the same time, I have to make sure that I do not use the anti-diarrheal agent like loperamide, right? Now, another station, traveler returned from Mexico with a moderate watery diarrhea. What is it? Traveler diarrhea. Exposure history, dehydration when empiric antibiotics help. So patient after clindamycin develops diarrhea. After clindamycin, so this antibiotic-induced diarrhea, which could be Clostridium difficile, targeted testing and treatment, stop the medication, supportive management, and then if the patient is getting not improving, then I have to add the vancomycin. If things are getting very worse, the patient develops hypotension, shock, or ileus. In that case, I have to add IV metronidazole as well. 8 weeks of diarrhea, weight loss, and nocturnal symptoms. What am I dealing with? Chronic, more than 4 weeks, right? Chronic, inflammatory malabsorption, alarming feature, broad workup. Greasy, foul smelling, and vitamin deficiency sign. I'm dealing with steatorrhea. It could be celiac or it could be pancreatic insufficiency. Young adult with a diarrhea, oral acid, joint pain. This is more like IBD. Which type of IBD? Crohn disease. Extraintestinal clues, right? Discharge, counseling after self-limited illness, counseling station, ORS, precaution, red flag, and safety net. Thank you very much. Wow, it was very long.